with time you'll come and understand these terminologies. So that's the definition. Is a primary glomerular disease characterized by proteinuria, hypotenemic edema, and hypoalbuminemia. Sasa. So it's there are 4 types of nephrotic syndrome. We have the idiopathic nephrotic syndrome, divided into minimal change nephrotic syndrome. Dominant, first are in children. This is the nephrotic syndrome. We have the secondary nephrotic syndrome, which occurs in children, about 10% of all cases. This may occur due to some form of chronic nephritis or diabetes, SLE, malignant hypertension, and etc. The congestive nephrotic syndrome, it is rare but a serious and fatal problem, especially associated with other congenital anomalies of the kidney. Tumesema hapo mbele hizo hizi kina glomerulonephritis, and what about it is inherited as an autosomal recessive disease, and severe renal insufficiency and urinary infections. Yeah. Then the last one is the infantile nephrotic syndrome. The term is applied to nephrotic syndrome of infants between 4 to 12 months of age. Its major causes are this one, the NPHS2, and the diffuse mesangial sclerosis, the DMS. Then we have the etiology. We have the etiology is into 2. We have the primary and the systemic cause. The primary renal cause ni zile yenye nilikuwa naambia tu, the glomerulosclerosis, the acute post-streptococcal glomerulonephritis, hizo zile magonjwa. And then the systemic cause ni hizi infections, toxins, allergy, the bee sting, inhaled pollen, food allergy, cardiovascular diseases like sickle cell, the malignancies like leukemia, and others, for example, the systemic lupus, erythematous, and the anaphylactic purpura. Yes. So when we come to the pathophysiology, I tried to break down. So this is the pathophysiology of the nephrotic syndrome. Number 1 is the alteration in the glomerular basement. You see, this is the as we all know, the glomerulus, the main function of the glomerulus is to filter, and it's selectively permeable. So there will be an injury to the glomerular injury. Now, when the glomerulus is injured, the basement of the glomerulus is injured, we know it selectively allows some things to pass through. For example, proteins cannot pass through because they have the proteins are large molecules, so it can't pass through the glomerulus. But now, when the glomerulus is injured, the basement is altered, protein will be able to pass through. So there'll be when the basement is, so the first one, which is the alteration of the glomerular basement membrane, so it will be altered. Then number 2, now protein will be able to pass through. The barrier will become abnormally permeable to plasma proteins, especially the albumins. Then there will be increased loss of protein in urine, which group 7 has mentioned, known as proteinuria, where you'll start, there will be presence of proteins in your urine. And then after, now you lose now the proteins, there will be decreased colloidal osmotic pressure. We know, or I'm assuming we know, that albumin is essential for maintaining the oncotic pressure, which means keeping fluid in the blood vessels. So when this happens, now that's when edema comes in, which is one of the clinical manifestations yenye nilikuwa nasema huko juu kwa definition. And then you have decreased vascular volume, decreased renal blood flow, and then the last one, there will be increased secretion of aldosterone. So I'll try and explain this. There are four main symptoms of nephrotic syndrome. We have the proteinuria. So vile nimewambia, when the basement, when there's the glomerular injury, kutakuwa na protein will be permeable, hence ndio utaipata sasa. That's why protein will be present in your urine. And then we have the hypoalbuminemia. So this is just low levels of albumin in the protein in the blood. And then hyperlipidemia. So hyperlipidemia occurs when protein is lost. There will be high when you lose protein through the urine, the liver will work harder by increasing protein synthesis to compensate the protein which is lost. So when there will be an increased synthesis of proteins by the liver, this will lead to an increase of fat production, hence hyperlipidemia. And then edema, si hapo hivi nimewambia decreased colloidal osmotic pressure. When albumins ndio inakuanga responsible for maintaining the oncotic pressure. So when there's a low oncotic pressure in the blood vessels, the fluid will leak out because the blood vessels will not be able to maintain the fluid inside. The fluids will leak out of the blood vessels into the surrounding tissues, resulting to swelling, which is basically edema. Then these are the other symptoms, clinical manifestations. We have shortness of breath, mild headache, fever, rash, joint pains. We have weakness, malaise, anorexia, weight gain, periorbital edema, irritability, these ones and so on and so forth. So when you come to diagnosis, we have the palpation due to edema, the swelling, and then you have the urine analysis, hematuria, and then you have the 24-hour urine. Normally you are supposed to, if by any chance there is a protein in your urine, it's not supposed to be greater than 3.5 grams per liter in 24 hours. So when there is presence of proteins in the urine that is greater than 3.5 grams in a span or in a period of 24 hours, that can indicate proteinuria, which is a abnormal amount of protein in the urine. And then we have the blood test. We can do the BUN, the S creatinine, the S protein distresses, the lipid profile shows. Then in one of the clinical manifestations, we've mentioned hyperlipidemia. Now you can do the lipid profile to show the high level of S cholesterol. Then we have the CMP. We can do the needle biopsy of the kidney, ECG, X-ray, renal ultrasound, renal scan, intravenous urogram. Management. The goal is basically to reduce the protein excretion. And as our lecturer was speaking previously, he said if something is the cause, you focus on how you manage it. So, for example, if the causative agent is streptococcal, then it's treated with, for example, penicillin, antibiotics, and then proteinuria after that is this just the drugs, those daily dose of 2 mg kilogram daily orally as a divided doses for 6 weeks is given. Thereafter, this is just the medicine, ni kama nursing care plan, and then kapo kwa interventions and stuff. So expectation is the proteinuria will disappear within the first week of therapy, and negative dipstick for 2 consecutive days shows a positive response to treatment. And then frequent relapses are treated by alkylating agents such as cyclophosphamide metformin, ngori, 2 milligrams per kg daily for 12 weeks. These are just the drugs. Then some lifestyle uh, changes. For example, well-balanced diet rich in protein. Because you are losing protein, you have to try and replace the protein being lost. And then sodium is restricted when marked edema is present. Then you provide high protein, as I've said, and high carbohydrates diet to patient. Uh, in advanced stages, avoid protein intake because it is affected to the kidney. Yeah, nursing management. Hii ni nursing care plan tu. The diagnosis, risk of infections, uh, fluid and electrolyte imbalance related to edema, impaired skin integrity and related to disease process, altered nutrition related to anorexia. Hizi ni zile symptoms nilikuwa naambia huko juu. And then care during hospitalization is the same as management, as I've just mentioned. Administer the drugs. Yeah, maintain fluid and electrolyte balance. Either oral or IV should be strictly monitored. You monitor also the sodium level, uh, daily weight, and venous stasis. And then we have prevention of infection. You put the infant, or for example, on immunosuppressants, the the corticosteroids therapy. Yeah, and then there is loss of immunoglobulin. You know, what I forgot to mention is that there can be an increased risk of infection. For example, we learned about thrombosis. There was you lose proteins in the urine that normally help to prevent clotting. For example, the antithrombin 3, the protein C, and the protein S. So the liver makes more clotting proteins, hence blood becomes more prone to clotting and higher risks of thrombosis, especially in the veins. So yeah, basically that's the prevention and infection. And then promote rest, provide passive play to the child as tolerated, e.g. watching TV and stuff. Yeah, I'm done. Thank you. Uh-huh. Someone else will take you through the glomerulonephritis.
Okay, we're going to talk about glomerulonephritis. So, introduction. It's a term used to refers to several kidney disease characterized by inflammation either of the glomeruli or the small blood vessels in the kidney. Can you hear me?
Yes.
Yes.
It occurs due to repeated episodes of acute nephrotic syndrome and nephrosclerosis and hyperlipidemia. Okay, so this is the definition. It's a kidney condition that involves damage or inflammation of the glomeruli. So we have the anatomy and physiology of the nephron. The nephron consists of a tubule closed at one end to form the cup-shaped glomerula, which is the Bowman's capsule, which almost completely enclose a network of tiny arterial capillaries of glomerulus. So the remainder of the nephron is about 3 centimeters long and is described in 3 parts: the proximal convoluted tubule, the loop of Henle, which is also called the medullary loop, and lastly the distal convoluted tubule, leading them to the collecting duct. Etiology and risk factor. So we have the streptococcal infection of the throat. We have the hereditary diseases. So we have the types of the glomerulonephritis. So we have acute and chronic. Acute begins suddenly. It occurs after 5 to 21 days of streptococcal infection. Then chronic glomerulonephritis develops gradually over several years. It occurs after the acute phase. Then you have pathophysiology of the glomerulonephritis. Due to any etiological factor, it leads to the release of Ag substance into the circulation. Then there is the formation of AB. Next, you have the formation of AB, Ag and AB complex in the glomerulus. Then it leads to an inflammatory response, proliferation of epithelial cells lining the glomerulus, then leukocytes, infiltration of the glomerulus. Then finally, you have thickening of the glomerular filtration membrane. So, continuation, we have the scarring and loss of glomerular filtration membrane, then decrease in the glomerular filtrate and glomerulus plasma flow, retention of sodium and water, then it leads to edema and hypertension. So we have the clinical manifestations. So we have the flank pain, foamy urine, the cola color or diluted iced tea colored urine. Then we have hematuria, oliguria, dysuria, then fatigue to anemia and kidney failure. We have hypertension and fluid retention. So diagnostic evaluation. So here we have the first step is history taking. Then the second step is physical examination. The third step, you do the urinalysis, then biopsy, then the IVP. Yeah, so we have the management. Then the treatment depends
Victor,
on the cause of the disorder, type and severity of symptoms. High blood pressure may be hard to control. Controlling high blood pressure usually the most important part of the treatment of glomerulonephritis. So we have the dialysis. Most of you have heard about dialysis. So in medication, you can administer the diuretics, the immunosuppressants, and the antihypertensive drugs. Then the lifestyle changes. So when advising the patient, you tell the patient to like sodium and water restriction, to restrict it, potassium, phosphorus, and magnesium restriction, like the patient should avoid intake of substances that have those minerals. Then limit intake of protein in the diet, take calcium supplements, then maintain a healthy weight through diet and exercise. Then we have the physiotherapy treatment. So lymphatic massage to reduce edema, breathing exercise, which is pursed lip and diaphragmatic breathing, endurance exercise such as walking, swimming, bicycling, dancing. These exercises improve the blood circulation and also accelerate the kidney to discharge the waste and toxins. So we have the complication, acute and chronic renal failure. Also, we have nephrotic syndrome, we have hypertension, we have pulmonary edema, we have CHF due to fluid overload, then we have hypertension.
Well, nephrotic syndrome and also glomerulonephritis. When we talk about glomerulonephritis, we are talking about group of diseases that cause inflammation and damage to the glomeruli. We know what the glomeruli are, those filtering units of the kidneys. And if they are affected by either inflammatory processes or damage to them, then it's going to impair the kidney's ability to filter blood. We know, of course, filtration is one of the key functions of the kidneys. So there are various pathophysiological mechanisms involved in glomerulonephritis. We have immune complex related mechanisms which can be caused by infections like post-streptococcal infections, some autoimmune diseases which now affect the glomeruli, and thus they cause inflammatory reactions to the glomeruli, and that leads to tissue injury to the glomeruli. Then we have other mechanisms like the antibody-mediated diseases, which again affect the glomeruli, which lead to inflammatory cell recruitment, which eventually can affect the glomeruli, and that's going to affect, of course, the filtering capability of the glomeruli. We have others like structural changes in the glomeruli, which could be as a result of infiltration by leukocytes, which again can easily affect the glomeruli, or sclerosis, where now scar tissues now replace the functional glomerular tissues, and that's going to cause decreased filtration. So the clinical consequences of all those mechanisms is that there will be hematuria, which will be, of course, from the glomerular bleeding as a result of the membrane damage of the glomeruli. There will be proteinuria, which, of course, because of increased permeability of the glomerular capillary walls, and because they increase permeability, now they're able to allow the protein substances to be filtered, and that can be seen in urine. Hypertension, which is as a result of salt and water retention. Because of that, decrease the glomerular filtration rate, because now you are talking about effects to those filtering structures. Reduce the glomerular filtration rate because of the inflammation, because of the swelling, and also occlusion of capillaries. Also, edema can be seen in those with glomerulonephritis. When talk about nephrotic syndrome, which again now also affects the nephrons. Nephrons, again, various mechanisms involved, and the effect of it is that there will be proteinuria. Of course, again, because of the increased permeability, which leads now to loss of some of these proteins, more especially albumin is the primary protein that is lost. Hypoalbuminemia, which is because of now reduced serum albumin, which is again lost with urine. Edema formation, because of now the fluid shift within the intravascular and the interstitial spaces because of the sodium and the water retention. Increased risk for infections because, of course, there is the loss of the immunoglobulins, which again disposes this individual to immunosuppression. So with the nephrotic syndrome, there's again glomerular injury. You'll get to see now those things like the proteinuria, hypoalbuminemia, edema, hyperlipidemia. Talked about loss of the various immunoglobulins, which again makes the patient immunosuppressed and at a high risk of developing infections. Any question to that point? Any question?